Hi guys, good evening to everybody, and I think we can get started for a quick recall session with respect to INI-CET May 2024. So, hi insignificant, I get to touch base with you once again, and okay, Sudeep, that's thank you for that kind suggestion, and okay. So the disclaimer is that these questions are based on recall, and once we are able to improvise on the options, then the final section or the final version would be uploaded in the app. Then the final section. Okay. Hi, Babu, Dr. Shambhunath, Anuj, Dr. Yashwat, Dr. Khalid, Dr. Kavi Zahu, Dr. Muhammad Anas, Dr. Priya. So good evening to everybody. I think if I missed out a couple of names, please apologize. I apologize for the same. And yes, guys, please let me know with respect to very good evening, guys. Let me know whether this was the image that actually came in the exam. And then I'm gonna focus on, yes, thank you, Dr. Ron. Thank you so much. So let me know whether this was the image in the exam with respect to the EEG pattern. And the hack for this one would be that, yeah, Riddhi, I agree to that. It always has been, it's always been tricky. The hack for this question is that don't focus on the EEG recording, but rather focus on the electromyography. And it almost is a flat line in this particular case. Yeah, it's a repeated question, Imran. The main thing that I would just like to highlight is that REM phase is where the muscle tone is the least. So I think this was the image, and EMG is almost touching the baseline. This indicates that the muscle tone is minimal. And at that point of time, you are getting spikes with respect to electrooculography as well. And you're getting that sort of pattern with respect to REM. So I think we are sorted for this very first one. And no, Roshan, it's not like that medicine is represented less. They try to give a paper which is more integrated. You can see microbiology, they had so many questions that were more or less based on medicine as well. So I think we are sorted for the first question that is currently on the slide, and I all agree that this was REM. Pranam, Kanishk, and hi, Dr. Rakesh. Starting with the second one, this talks about a 30-year-old male who's admitted to the medicine ward with vomiting and diarrhea, and then he gave a low potassium values. Do let me know whether the options for the question are the same. Hypokalemia is what he is talking about, and hypokalemia can result in. Okay. Neil, for differentiation, you need to check out the EEG report along with the electromyography report, as I always say. And the electromyography that I have got a feedback was almost a baseline. And this is the standard image which is present in rapid revision also. So do have a look at this image and let me know. Most guys I talked to, they emphasize that the image was the same one, which is for REM. Okay. So Neil, that's my hint. I mean, try to focus on the EMG concomitantly. The options are the same. The logic is two options. I think everybody could rule out that hypokalemia can contribute to development of torsades pointus. So ventricular tachycardia is fine. And then hypokalemia also causes muscle weakness when it's going to be present. And because of this muscle weakness component, there can be paraplegia as well as quadriplegia. You are left between two options, diabetes insipidus and cerebral edema. And you are aware of the fact that cerebral edema per se is mainly related to fluctuations in the value of the sodium. When we have presence of hyponatremia, that's where cerebral edema component can come. But potassium does not play a role with respect to plasma osmolality. Considering that cerebral edema is mainly related to sodium fluctuations and not related to, I would say, potassium. This looks to be the answer, but I'll give you the rationale for option number C also. The rationale is that in setting of hypokalemia, we usually get a resistance to antidiuretic hormone action. And the reference for the same is given from Harrison as well, is the page number as well. And because you are having resistance to antidiuretic hormone action, that is why even polyuria can be present in these patients, diabetes insipidus. So the correct answer for this one would be option number D, that would be cerebral edema. There are two ways to hack this question. The easier one is what I said, cerebral edema is going to be related to sodium per se. And I mean, because past plasma osmolality formula is mainly based on sodium concentration, almost like out of 280 milliosmoles, almost going up to 270 would be value of sodium itself. I mean, that's the biggest chunk contributor to plasma osmolality, which is why cerebral edema develops in case there's going to be fluctuations with respect to sodium values. So we are sorted for this one, and the reference for Harrison for option number C is also there. So it's just that I had to give you a reference for the same as well. Then was a question which is a patient who's unconscious. I just want to know whether this was any blood pressure value given or was it unconscious. And then there was a narrow QRS or narrow complex tachycardia. I think it was narrow QRS complex tachycardia. So this is gonna be possibly a PSVT, and because the person is unconscious. Okay, okay, Ishan, that is a good thought process. Calcium affecting plasma osmolality, but then it's sodium that would primarily affect the sodium osmolality. Okay, so since the person is altered mental status, okay, so if he's mentioning altered mental status, then we straight away have to go in for DC shock. I mean, we have discussed multiple times, except for atrial fibrillation, in all other tachyarrhythmias which are gonna be sudden onset, we have to go in for cardioversion. We don't go for cardioversion in atrial fibrillation because there are clots. लेकिन बाकी सब में तो क्लॉट्स जो होते हैं वो मतलब प्रेजेंट नहीं होते हैं, सो वी कैन स्ट्रेट अवे गो फॉर अ सिंक्रोनाइज्ड डीसी शॉक इन दिस पेशेंट. एंड okay, unconscious word was not there, but altered mental status was there and low blood pressure was present. So got it, doctor. I mean, I get your point, but the gist of the question and the concept of the question is still the same, that in any unresponsive patient with acute onset manifestation of a tachyarrhythmia, apart from atrial fibrillation, we have to go in for uh, synchronized TC shock. Yeah, transesophageal echo, Abdul, you're right, it would be done with respect to atrial fibrillation. But in this particular case, we are talking about a PSVT, narrow QRS tachycardia. So it's a supraventricular tachycardia that we are talking about. So I think we are sorted for this one also. And as far as the remaining options are concerned, they would be given in a hemodynamically stable patient. If it was a blood pressure that was repeated, okay, Imran, that's great. So if it was a hemodynamically stable patient, we would have gone ahead. And amiodarone I can rule out because amiodarone would be useful for patients who are having a broad QRS tachy. Doctor, we are coming to that question of atrial fibrillation. Dr. Kanishk Jha, I'll just come to that atrial fibrillation question in few minutes from now. So just be patient. There were two questions and the atrial fibrillation one is on the agenda very soon. Okay, now moving to the next one. This was a case of, I think, viral pericarditis, and then there is a pericardial effusion. And then that effusion has become so big that it's going to contribute to development of a cardiac tamponade. So, I mean, since there's a viral infection present, so I can say first it started off as a viral pericarditis, but then it started evolving into a pericardial effusion. And then as the pericardial effusion has become bigger, it will compromise the ventricles. There will be a diastolic collapse of the ventricles, as is given in the question, that is tamponade. So everything fits the bill for that. There is going to be a compromise of the heart. That's what is written, collapse of the ventricles. You would have muffled heart sounds are there. Yeah, one option was there, diastolic collapse of the ventricles. Yeah, okay, I'll add that word, diastolic collapse. So I was saying that verbally, but great. I mean, that was a very good input, doctor. Thank you for that word, Dr. Prashant. That would be diastolic collapse of the ventricles, so it would require an intervention, that is emergency pericardiocentesis. What's that word? Emergency? I mean, pericardiocentesis is usually done on an emergency basis only. So I just want to know whether that emergency word was there. Yes, guys, you were right, perfectly right. They would not be allowed as one because there is water outside the heart, so there has to be a muffled heart sounds present, and that is why Raju, Aman, Alia, Sudeep, all of you are right for this. But let me know whether emergency word was there or not, because that anyway, that would not change the answer to the question, but just out of curiosity, I mean, I just wanted to know. Pulsus paradoxus is a feature for tamponade, inspiratory follow blood pressure values more than 12 millimeters of mercury. Okay, so fine, guys. Thanks, Abdul. Thanks. Okay, emergency word was not there. So majority in tachycardia, yeah, doctor, but in this case, even if there is a tachycardia, no, even then you would have, because there is water outside the heart, no, so that is why even if there is a tachycardia in this case, I'm not gonna be able to hear that, no. So I agree to the fact, Soumya, that they would be allowed as one. There could be a tachycardia described in the patient, but yep, in spite of that, the water outside the heart is gonna prevent the auscultatory finding of a loud S1. Okay, so let's move on to the next one, a very easy one. Purple stretch marks in a man along with obesity and easy bruising. That would be Cushing syndrome as a presentation. Pericardiocentesis is done in traumatic. Dr. Islam, I spoke about this in patients of, I spoke about this in LRR, the LRR section. there was a question that I had covered that in a traumatic by traumatic, you mean stab injury to the chest, right? The question that you were talking about in a mock test of a platform, it was traumatic injury to the chest. So there's a hole in the heart which is causing bleeding. So you need to fix that. That is why thoracotomy is the answer. Otherwise we do pericardiocentesis only. But in case of traumatic by a penetrating injury, not blunt injury, I'm saying penetrating injury to the heart, penetrating injuries to the great vessels in the chest, we have to do a thoracotomy in the patient. So I think that is the questions, Dr. Samuel Islam, that you're talking about. I've sorted that out. And this is going to be Cushing syndrome. Okay, okay, Prashant, that was a good input. In fact, I'll just jot it down here as well, that there was a mention of the vitals of the patient, and the vitals was showing a presence of a tachycardia as well. So, okay, so that would be confounding factor in the question, but at the same time, the loud S1 part would still not be present, considering that the remaining things fit the presentation of cardiac tamponade. Okay, Prashant, I agree to that confounding factor being present in the question. Okay, so we are going to have a very good debate about this one. We are having a patient who's presenting to the OPD with headache, abdominal pain, and recently developed renal stone. Let me know if there was anything like serum calcium is low. Most of my boys who are with me in my group, they said serum calcium was low. So I just want to know that serum calcium being low and PTH being high was present in the stem of the question or not. Okay. Okay. So if we look at option number A, primary hyperparathyroidism, that will be having increased serum calcium and will be having increased PTH. Yes, yes, it was extremely low value. Okay, okay, Amrit. Okay, no, no, doctor, don't jump to the answers. It is not option number A, if you look at it that way, because in primary hyperparathyroidism, there is gonna be episodic headache. Okay, okay, that's a good one, Abdul. So that's again a compounding factor, because episodic headache would make you think in terms of pheochromocytoma, but there was no mention with respect to pheochromocytoma present in the question, because there was no hypertension, no diaphoresis described. Uh, okay, hypothyroidism. It's not hyper, it is hypo. Okay, got it. Oh, got it, doctor. So in hypothyroidism, features are going to be different. There's going to be weight gain, there's going to be cold intolerance in a patient, so I can rule that out. Pheochromocytoma, the presentation would be that of PhD. Okay, low mood in the patient. Okay, great, great. So I think the question can be solved on the basis of recurrent stones. Okay, developed recurrent stones. Weight loss also. Okay, okay, weight loss in the question. Fine. I would just like to for just ruling out that stones, bones, and groans thing. Was there any mention of any psychosis in the question? No, no, Amrit, I agree to you. If there is manifestations of there is a low mood, that is okay, because patients of CKD will also be having the same issue. The basic bottom line is that because there is low calcium and there is an increased PTH in this patient. So whenever I was talking with my group students as well, they were telling me that this was I mean low calcium increased PTH. So it goes in favor of Neil, I agree to you, but then you see, we also have to take into consideration low serum calcium. Low serum calcium cannot be a presentation of primary hyperparathyroidism. It has to be secondary hyperparathyroidism as a case. And then after a lot of deliberations, I found this terminology from one of the doctors that this was mineral and bone disorder. Then mineral and bone disorder basically means renal osteodystrophy. I put up a reference for the same also. I mean, mineral and bone disorder is CKD, because one of the leading causes of secondary hyperparathyroidism is gonna be chronic kidney disease. So considering the fact that there is a low serum calcium in the patient, the correct answer for this one would be option number D. Yeah, yeah, absolutely, Amrit. Confusing because the options, because the yes, yes. Amrit, you're perfectly right. But since we are now having a refined version of the question, because earlier that option number D was the one that I was searching for. I mean, most people were saying bone disorder. So bone disorder is a very non-specific thing. But once we start talking about mineral bone disorder, that makes more sense, because that's gonna talk about renal osteodystrophy. So we have to take laboratory values into consideration as well. I mean, the symptoms, I would say like this: secondary hyperparathyroidism is not a cause for kidney stones, but it can be associated with development of kidney stones in a person. And the remaining features are like, I mean that weight loss, low mood, they can be features present in patients of chronic kidney disease as well. And that headache part can be explained by even the hypertension component, because CKD, the GFR is going to be low, so there's going to be increase renin values, and that's going to explain the hypertension in the patient. Okay, medic, that's an interesting one. By looking at the lethargy, which was described in the question, and you thought hypothyroidism, that's okay, doctor. I get your point, but then the lethargy part that is mentioned is not very specific word. We need to pick up words like cold intolerance. We need to pick up terms like significant weight gain, myxedema, or feature suggestive of myxedema that can be present. So, okay, Doc, thanks for the input for this one. And yes, insignificant, thanks for your input as well. I think you did not comment anything at the moment because you already done your part. So I really appreciate your inputs for the same. And yes, Abdul, thanks for that input as well. Proximal muscle weakness. Okay. Okay. Serum calcium is low and increased PTH. Doc, I agree to all the points that you're saying, but then point is primary hyperparathyroidism. My only point is, I mean, if serum calcium is low, then I'll say option A. If I and that is the first thing that I put up there. That I mean, if I remove this from the question, then I'll say that it is option number A only. But I began by asking regarding whether there was a low serum calcium, because to have a low serum calcium in primary hyperparathyroidism, I mean, it's gonna be highly insignificant. So, okay. So we are sorted for this one. Let's move on to the next one, which was an easy one. So don't worry. I mean, maybe this one was a tricky one for you guys, but you'll be able to solve this one. Serum calcium was normal. Okay. Fine, Suresh. I agree to what you're saying, but then even then, I'll consider it as a possibility. Why not pheochromocytoma? Okay, interesting. Pheochromocytoma, doctor should be having palpitations, it should be having hypertension. I mean, at least blood pressure value तो होना चाहिए ना, बिना hypertension के तो नहीं बोल सकते ना pheochromocytoma in a patient. So episodic headache is not the word, it is episodic hypertension that is a presentation. No, doc, not that's what I'm trying to say. No, episodic hypertension को नहीं मानेंगे, right? It's gonna be episodic headache is not to be considered. It's episodic hypertension. Okay, so for diabetic ketoacidosis, we had a person whose blood sugar is elevated. The CMDT reference is there. I think this was an easy one. I mean, you can pick up elevated sugar. It's gonna be a HAGMA, a high 9-gap metabolic acidosis. There's gonna be low bicarbonate in this case, but serum potassium less than 3.5 is that could be a presentation of the disease because of the vomiting component, but it would not be a diagnostic criteria per se. It's a manifestation of the disease. So that makes answer as D for this one. There was a question on CPR. The chest frequency rate is fine, chest recoil is fine, the cycle of CPR is fine. But when it comes to chest compression, Jasu, I got stuck up, man. Then chest compression is gonna be 5 to 6 centimeter. But love to all the students from Jasu, they really took very good care of me. So the chest compression rate should be about 5 to 6 centimeters. This was 3 to 4 centimeters. So answer is gonna be B. And yeah, doctor, I could not pick up your name. Do comment about how the situation is in Bishkek at the moment. I hope that all the students are fine, because I myself had a torrid time. Okay, so we sorted for B, and let's look at the next one, which was about a patient who is having obstructive sleep apnea. Daytime sleepiness, nighttime sleeplessness, and he snores a lot at night. So it all goes in favor of OSA in a patient. That would be obstructive sleep apnea. And whenever we are going to be having a presentation of obstructive sleep apnea, the main reason for that is going to be the collapse of the airways. And in this condition, I mean, it's not the increased tone, it's rather the decreased tone, and the reference for the same is also present. I mean, you guys know about it, know that there is going to be a near collapse of the airway, which will ultimately trigger a hypopnea or a development of a apnea in the patient as well. D, doctor, I'll say like this: low oxygen stimulates respiratory effort, because once there is a complete absence of snoring, he'll snore, then the snoring will stop because there's an apneic episode. That is the trigger for the fact that this person will now change his position and will start snoring again. So hypoxia is the trigger which stimulates the respiratory effort in this patient. Yes, Dr. Prashant, I'll be there. I'll be there. So, in this particular question, a nighttime wakening is apneic episodes are related to stress on the heart. They're related to waking up at night. All of them is gonna be the manifestations, but we'll not get an increased tone in this one. And the answer for this one would be A. So this we had deliberated pretty substantially, and let's look at the next one where my question is very simple. Were all the arrows going in upward direction? If the answer is yes, let's not fight about the mathematical values in this case. My only query for this particular question is that were all the arrows going in same direction? If they're yes, then it's going to be metabolic alkalosis. If they were not, then let me know the permutation combinations. Option C was apnea related to awakening. Okay, increased stress on the heart would be awakening. Which one, doctor? Obstructive sleep apnea? Obstructive sleep apnea has that chain strokes breathing pattern, no? That there would be a hypopnea, then apnea, and then a hyperventilation. Chain strokes breathing traditionally जो हम पढ़ते हैं वो तो raised ICP में पढ़ते हैं ना, but it is also seen in high altitude, and even the same pattern can be seen in obstructive sleep apnea as well. That would be no. See, doctor, what happens is this guy will snore so loudly that Gharwala will say that there is a tractor running in the house because that snoring will become louder, louder, louder. Then there is a collapse of the airway. Apnea will trigger nighttime awakening, so he will toss and turn in the bed. And when he will turn in the bed, he will again start snoring once again. So the breathing stops for a few seconds. And because of that, there is a sleep interruption. And that sleep interruption, he may not open his eyes, but in the EEG, there would be change in the pattern. That's because of the fact that there is a cortical arousal because of the hypoxia component. तो इसको रात को नींद आती नहीं ठीक से, इसलिए दिन में इसको नींद आती रहती. Nocturnal awakening is a manifestation. I mean, this is gonna be a patient who is जो ये बोलेगा कि मैं कहीं पे भी सो सकता हूँ, राइट? ही विल से कि मैं आपके टेबल पे सो के दिखाता हूँ. सो आई मीन दैट्स द अमाउंट ऑफ ड्राउजीनेस इन दिस गाय दैट RCB is getting kicked out of IPL and this guy is sleeping. Okay, in CMDT, atrial fibrillation should be done. Is patient is in hypotension? Yeah, doctor, it is accurate for acute onset atrial fibrillation, na? But atrial fibrillation, majority of cases is not an acute onset manifestation. Dr. Sanuja, you're perfectly right. If it's an atrial fibrillation, which is acute onset, then you do DC shock. But mostly atrial fibrillation is a sustained tachyarrhythmia. Okay, this one is metabolic alkalosis because all the arrows are going in same direction. And next we look at a question in which we had to calculate the anion gap. Mathematics is always a torture for me. Anytime I have to do it, though I think I'm doing it for the second time. This would be 4, 10, 104. So anything, I mean, this would be value more than 12 only. So this would be, we don't need actually a delta gap. I think a 9 gap calculation itself would be more than sufficient for us. This is going to be a HAGMA, a high in N-gap metabolic acidosis. And that's because this chap is having elevated blood sugar. So I knew that it's going to be diabetic ketoacidosis only because the pH is less. Just let me know if the arrows are going in same direction again for pH and bicarbonate. Any discrepancies in that? Any discrepancies with respect to question on SA node? Dr. Abhishek, my email is marvamedicine@gmail. So let me know if there's a question on SA node. Was it an ECG based one? I think it was a physiology one, but still I'll try to solve it there. Yeah, Amrit, that's great. So if the arrows are same and the directions are same, we are sorted for this one. This would be HAGMA, that is high anion gap metabolic acidosis. I'm coming to that atrial fibrillation question. I know you're waiting for that, so let's look at another one there. This is about a 55-year-old guy, alcoholic, who has come to the hospital in altered sensorium. Was this word there, altered sensorium? And then we can move forwards for the remaining options. Then vomiting and hypotension are interrelated. I mean, if he's going to continue puking, it's going to contribute to hypotension in this patient. So yes, Vansh, thank you. Previous binge and alcohol. Okay, Abhishek, I'll try to do that. Let me send me a snapshot at marvamedicine@gmail or in my Telegram group, and I'll surely try to assist you. Okay, considering that there's an altered sensorium in an alcoholic, so if I add up two things together, alcoholic and altered sensorium, I am thinking first in terms of possibility of either a hepatic encephalopathy in this person. That is one possibility. Another possibility is he could have gone into hepatorenal syndrome because HRS again, the kidney failure can contribute to development of altered sensorium in this person. And another reason for this could be plain hypotension because there could be bleeding varices. And though there is no mention of any bleed present in this guy, but I mean, okay, seizures in this guy as well. So this seizures also points towards a CNS event. I mean, if the seizures are also given in this question, PPI was given. Okay. Okay. Doctor gave PPI to this patient initially. That's okay. No history of seizures. No, doctor, it's not delirium tremens. It's not delirium tremens. Delirium tremens will always present with anger. It will always present with violence. I mean, delirium tremens patients will be having rage attacks. They'll not be unconscious. They'll be conscious. वो तो लड़ेगा आपसे. वो तो पैसे मांगेगा भाई अल्कोहल के लिए पैसे दे दो. There's gonna be tachycardia. There's gonna be hypertension. There's gonna be mydriasis. There's gonna be tremors in this guy. So delirium tremens presents with not unconsciousness. It presents with a violent behavior on the part of the person. And yes. Even if there is no mention of any seizure, altered sensorium, I'm removing it, guys. I'm removing the altered sensorium part. But in this particular chap, considering hepatic encephalopathy, see, I have to check out for varices in this guy because he's mentioning mild portal vein hypertension. But in an unconscious patient with altered sensorium and hypotension, it would not be a wise idea to subject him to go in for endoscopy right now. Why I'm ruling out option number B at the moment is that if blood pressure of a patient is low, it would not be a wise idea to go in for endoscopy at the moment. So I am ruling out option number B. I am ruling out option number C because where thiamine and chlorodiazepam are treatment for DT, but then the person has to be in his senses and he'll be fighting with you and will be begging you for money so that his life can be saved. I will plan a CT scan because I want to pick up cerebral edema component, which could be due to hepatic encephalopathy, and I'll do detailed investigations also. But considering all these things, the first thing for hepatic enceph is, at least in the emergency, if we can put in a NG tube in this guy, then that would be one of the wise things to do in this person, because I think the question was, what is the most appropriate next step? I mean, that's the wordings that I got, next step for management. So in an unconscious alcoholic, we will first plan to go ahead and give lactulose to this patient. Yes, Amrit, there's another pointer you have said, because alcoholic cirrhosis is there, so we'll not be comfortable giving chlordiazepam oxide. We'll rather be giving lorazepam for this patient. Yeah, vomiting, I've got, doctor, vomiting and dilated portal vein, that I understand is suggestive of portal hypertension in this chap. And that is why, no, I mean, all these features are, I mean, what does this signify? ये line क्या बताती है आपको? This line basically tells you that the chap is having a decompensated cirrhosis. I mean, हमें कैसे पता चलता है कि पर्सन को कॉम्पेंसेटेड है या डीकॉम्पेंसेटेड है? अगर पोर्टल वेन का प्रेशर बढ़ा हुआ है, डायलेटेड पोर्टल वेन है, तो डीकॉम्पेंसेटेड सिरोसिस है ना. This line of finding of workup of liver showing dilated portal vein, this basically indicates, the last line of the MCQ basically tells you the fact that there is a decompensated cirrhosis. So that is what I basically want to think in terms of that. Is he bleeding? There's no vomiting of blood. There's no renal failure that is documented at the moment. There's no evidence of sepsis in this person. So that is when I will think in terms of hepatic enceph for these patients. So I think that we are sorted for this one. Yeah, because he's unconscious, no? So I'll put in a NG tube and go ahead with it. Okay. Patient is a doctor in a low hypotensive patient, no? In a low blood pressure patient, endoscopy will not be a very wise thing to do on an emergency basis, ना. मतलब अभी आप मतलब all of us work in government hospitals, यार कहाँ पे endoscopy की facility होती है emergency में करने में, है ना? वो next step पूछ रहा है ना हमसे. मतलब अगर वो मुझसे बोलता है कि what is like the treatment plan for this person, तो मैं बोलता कि हाँ जी, my treatment plan is to look for possibility of varices also, apart from checking out hepatic encephalopathy, and I'll get a blood ammonia values done, I'll get a EEG of the patient done. But yeah, मतलब endoscopy is like बहुत बाद की बात होती है, पहले basic हमें initial step manage करना होता है ना. No, doctor, it will not become a nagma, na. The value would still be, if you calculate, my mathematics is bad, but if I do it, no, this is 104. So ये तो बहुत high है यार. You know, I think 90, 92 and 12. So that's a hagma, man. I mean, this would be very high values, no? This would not be an AGMA value. Even if it's anything value more than 12, this would go in favor of okay, so I think we are sorted for these ones. For Crohn's disease patient versus ulcerative colitis, I mean, though I've seen this recall with respect to, in various, I would say, forums, But I think the question was mainly framed about differentiating between the two, and option number A. Anonymous, if you can comment separately on this one, no, it would be really nice because going back to that one, last question. Okay, fine. Okay, what is lesser in Crohn's disease as compared to ulcerative? Okay, doctor. I mean, the gist of the question is very simple. That I mean, Crohn's is both ways. The question can be ulcerative colitis versus Crohn's, or Crohn's versus ulcerative colitis. So I think what is lesser in Crohn's as compared to ulcerative colitis? Okay. So then it would be hematochezia. Then it would be hematochezia because mainly, I mean, if he says what is lesser in Crohn's and ulcerative colitis is bloody diarrhea. If I go for this particular version, then I'll say Crohn's elevates the risk of Crohn cancer, so colon cancer, so that's fine. Does not have continuous lesions, but will be having skip lesions. So because both of these features are, I mean, option number B would be a feature of ulcerative colitis. Option number D is also a feature of ulcerative colitis, and Crohn's disease is a pre-malignant condition. So my language for this one would be, because he's saying which is the correct statement in this particular case. So no, no, doctor, it would not become a NAGMA, no. It would still become a HAGMA in that particular case, no. It would still be anion gap values are always gonna be in a range of 10 to 12 or higher than that, right? I mean, if there's an arrow which is mentioning that. Okay, seldom daily. Fine, fine, fine. Let me explain. Let me explain. If the question in this one says what is feature of Crohn's disease, then feature of Crohn's disease is going to be a perianal fistula. If he says it otherwise, which is unlikely to be present in Crohn's disease, then it is seldom presents with hematochezia. So I got both the versions of this question, and I mean this particular, yeah, yeah, that's what I'm trying to say, right? Seldom with hematochezia. Okay, so if okay, let's do this one. Let's do this activity. In fact, that's very interesting. Uh, it manifests with hematochezia. I changed this to seldom presents with hematochezia. So okay, fine. Even if I go with this particular statement, no doctor, that even with option number D, seldom presents with hematochezia instead of saying presents with this, still the characteristic feature of Crohn's disease is gonna be presence of perianal fistulas. I mean that I have emphasized multiple times that the hallmark feature which differentiates Crohn's from ulcerative colitis is not hematochezia. It is not the bloody diarrhea component, because the diseases can be having overlap as well. The main differentiating feature between the two is presence of perianal fistulas. You can check it out in the textbook as well. I think on based on the current wordings also, even if I go with seldom presents with hematochezia, well, it's ulcerative colitis. It's gonna be perianal fistulas which would be there. Doctor, got it. I mean, the gist of the question is very clear. He is asking us that which of the following is true or which of the following is not true but Crohn's disease. So if it is gonna be true, then it is option number C. If he's gonna say which is not true, then obviously the reverse statements that I mentioned would be satisfied. Cancer incidence is equal in both of them. Cancer incidence is equal in both of them. Okay, moving to the next one. Let's say all of the following are risk factors for headache. Ulcerative colitis and Crohn's वाले पे I think ज़्यादा debate नहीं करते. I mean, I think depending on the language of the question, the answer would be okay. Yeah, yeah, bone and metabolic bone disease. Yes, doctor, that's what I'm saying. No? Bone and mineral bone disease is what I've highlighted. That would be a terminology specifically for secondary hyperparathyroidism. Okay, Dr. Iftikhar, thank you so much. Yeah, except I've added only 50 years. I'll add that 50 years. Okay. See, option number B will be a component of this because cord-like vessels will be a feature of giant cell arteritis, and subacute worsening is also a feature that is suggestive of intracranial space-occupying lesion. So at least option number B and D are gonna fit the bill in this case, and I'm left between only two options in this one. That would be okay, okay, Amrit. Guys, let me know what no multiple options or was it a single option? Okay. Okay, then fine. I'll solve the question for you. If it is gonna be let's just, even if I remove this, two options are sorted in this one. And if a person is 50 years of age and there's a headache in that person, I have to be wary, because in old man, new onset headache is always a cause of concern. So I mean, this is obviously a concerning fact, and I would like to investigate the person. Even if it's an accept MCQ, the answer for this will turn out to be option number C. And I mean, if I go by multiple responses, it's going to be 3. If I don't go by multiple responses, it's going to be answered as which one would you not evaluate? यार कोकेन तो आजकल लोग routinely लेते रहते हैं ना, तो कोकेन वाले के लिए मतलब मुझे टेंशन नहीं है. कोकेन will cocaine is going to contribute to development of headache, because it will cause vasoconstriction, it will increase the blood pressure of this person and would contribute to problems. Okay, fine. Yeah, single option. That's okay, doc. I mean, still we get to the correct answer. That is option number C is the one that has to be ruled out for this one. Okay. Yeah, I got it. I got it. All of the above will require investigations except. So the gist of the question is very well. Risk of ICH with cocaine. Abdul, cocaine overdosage is something that I'll be worried about with IC bleeding, but cocaine usage, if there is a mention of a cocaine like abuse, or if there is a mention of a cocaine overdose, I think overdosage word should be mentioned, right? Otherwise, it would be onset was not there, only 50 years of age. Okay. Dr. Vinita, cocaine is something that people are taking on a recreational basis nowadays. So cocaine usage, if it was like, that's what I'm trying to say, no, if it was a cocaine overdosage, I'll be a little worried, but not for a patient who would be, for using it for recreational purposes. Yeah, Krishna, thank you so much. I'm perfectly fine and safe. Thanks to all the lovely people who took very good care of me back there. Situation was bad. Okay. There is no mention of severe in the first option. Yeah, doc, I removed that. Even in an old man, no, even if being 50 years of age, in a person, if there is like a person who's 50 and is having features of headache, if I'm selecting between age versus drug usage, then I can say that age would be a more important factor. And there's a table. Yeah, that's okay, doctor. I mean, onset after 55 years of age. So I will not say that that's a golden rule that it will always be 55 years of age. But okay, Amrit, I'll check up in Davidson as well. Temporal tenderness is considerable. Ixol is intracranial space occupying lesion, doctor. This could be like a brain tumor, right? Subacute worsening over a couple of weeks is always a feature of intracranial space occupying lesion. Fine, guys, I got the gist of the question, and I can just say at this moment that if I have to select between an old person with a headache, that would be a cause of concern. Yeah. Fine, guys. This is the atrial fibrillation question that we were debating about, and now it is in front of you. Okay, Hemant says cocaine overusage. Mm-hmm. Okay, fine, doc. If it is a cocaine overusage, I'll still have to consider a possibility there. But I think it was cocaine usage only. Cocaine overdosage, if it is given, yeah, consider. I'll take into consideration possibility of a brain hemorrhage in those circumstances. Okay, now it's coming 55. So we will go by textbook here. मतलब textbook वाला जो data है ना, that is the final one that would be present, because in this entire table is mentioned the way it is. But Hemant, I'll take into consideration once we come out with the final version. I'll take into consideration your suggestion as well. 50 age is fine. That वो तो मैं टेबल दिखा रहा हूँ यार. That what I'm trying to say is कि वो 55 साल लिखा है, तो जरूरी नहीं है कि 55 पे स्टार्ट होगा यार. 52 पे हो जाए, 50 पे हो जाए. Okay. Mhm. Yeah, so may we sorted that out. It is not a multiple correct option, so that is why I've given both the versions of the question. Yeah, only history of cocaine usage is there, so we will consider that, because that can be recreational as well. Okay, which of the following statements about this chap who's unconscious? I mean, let me know if unconsciousness was there in this case as well, and the patient is having a irregular RR interval. And considering this irregular RR interval, this would be atrial fibrillation that is present in this person. And then he wants me to select which of the following is false. So option A says rare occurrence in individuals with a normal heart. Atrial fibrillation is one of the commonest arrhythmias that would be seen in patients who are having structural damage to the heart. Most of the time, it would be occurring in patients with hypertension or with cardiomyopathies like dilated. So, I mean, this is a correct statement. I'll say like this: this is rare to have this thing in a normal heart because you need most arrhythmias occur in damaged hearts except PSVT. PSVT is the only one that is seen in a structurally normal heart. DC shock is something which should not be done in atrial fibrillation, considering that if we do it directly in atrial fibrillation, then person would possibly go into a possibility of a stroke as well. Okay, he's saying which of the following is a correct statement in this case. Okay, okay. Fine, guys. Let me just work out the options and then we can use this one. Uh, okay, fine. So this would not be a correct one. Intravenous digoxin is used for rate control. Then, yeah, in a setting of heart failure, we will use intravenous digoxin in this particular case. If you ask me that which of the following is the correct statement, then the most important correct statement is that there would be presence of a pulse deficit. Like in this particular case, if there is a true statement, the most accurate statement, that is discrepancy in heart rate and pulse rate is used for this person, because that is gonna be pulse deficit per se, does not occur in, yeah, does not occur in normal heart. That's a rare occurrence. I mean, I think option number A would be a correct one in this particular case. And intravenous digoxin is useful for rate control, yes, in a setting of atrial fibrillation with heart failure. Because if it's gonna be atrial fibrillation with congestive heart failure, then I cannot be using beta blockers in this patient. So I can be using digoxin. Okay. Cardioversion required in all of these cases. Fine, doctor. Let me first give the answer to the current version in this particular case. If it is false statement, then option number B, this is the wrong statement in this particular question, that direct cardioversion must be done for all cases. We do not go ahead with direct cardioversion primarily because of the risk of stroke in a patient. Now let's go to the most appropriate statement for this condition, because the wordings can be varying. Because for rate control regularly, we don't use digoxin nowadays. For rate control, first line is beta blocker, or we can be using calcium channel blocker in a patient. So if you ask me that which of the following is the most reliable criteria for diagnosis of this condition, then the main feature is pulse deficit value. If pulse deficit, that is pulse rate and हार्ट रेट इज नॉट मैचिंग बाय वैल्यू मोर देन 10, हमें तो मैच करती है राइट, थोड़ा बहुत एक दो का डिफरेंस होता है, बट इसमें बिकॉज द हार्ट इज बीटिंग सो फास्ट एंड द रिदम इज नॉट so रेगुलर, you might miss out a couple of pulses. So the most accurate way for diagnosis of that person would be discrepancy in heart rate and pulse rate. So given two versions of the same, if we say false, then I mean DC shock would not be done in all cases. If he says which is the most accurate statement for this one, then the most accurate statement for this one would be that discrepancy in the heart rate and pulse rate is useful for diagnosis of this person. So I think let's not bother about it, guys. But the objective of this session is mainly to emphasize what is the correct thing, and the correct thing is what I'm trying to explain to you, that pulse deficit would always be uh, I mean, pulse deficit per se is the main diagnostic criteria for atrial fibrillation. Ventricular rate control. Okay, I'll add that, Amrit. That's a good input. Ventricular rate control. But then again, we don't start with digoxin. वो तो पुरानी बातें हो गई. Only in atrial fibrillation with heart failure is when we use digoxin in the patient. Yes. So I think we are sorted and had a good debate on this one, healthy discussion. And I have a reference for this one which people were looking for, that when would you use steroids in a case of immunoglobulin A vasculitis? So the reference is there, guys, that these are guidelines from European Society only, and this mentions that we would be using steroids in those cases where there is a presence of a bleeding, or if there's a possible risk of a perforation, but not for cases of abdominal pain, because abdominal pain was also in the options and bleeding was also in the options. Okay, Sneha, you said only cardioversion was mentioned. They probably meant medical or okay. Okay, fine. I'll remove that, doctor. I'll remove that. Even if I remove that option, no, still then cardioversion must be done in all cases is not a very accurate way, because directly, I mean, initially we do not go ahead with cardioversion in these patients. But I get your point, because we are looking at the other version of this question, the one that you're talking about. So I get the point. If we go into what is the true statement for this one, then still I'd go by option number D only. No, guys, I don't think so. We need to be like when we treat patients, when somebody like if we are not able to take care of somebody and somebody has a bad prognosis, we don't cry. And when we are able to save somebody, we don't go to, DLF mall and we start celebrating at the fanciest pub, right? Similarly, here you have to be emotionless with respect to questions. That would be my request to you guys. And yeah, Hemant, I get it. Nor almost never seen in structurally normal heart. Okay, so that will help us work out the other version of the question, no? Because I give you the false one, and then if you go by almost, then that helps us come out with the correct ones. Okay. Okay, let's move on to the answer for this one. That would be GI bleeding, and the option was there arthralgia. Okay, fine, guys. I think that would be option number A then, joint inflammation. That would be arthralgia. Okay, fine. So since we have a reference for this one, joint inflammation and arthralgia was also there. Okay, fine, not an issue. I get it. I get it. Arthralgia is also there and arthritis is also there. समझ गया. So option A was arthritis. Option D would be arthralgia. Great. Okay, I'll change that to abdominal pain. Yeah, petechial rash. I mean, dermatological eruption. Uh, Taking a drop. We'll debate that, doctor. We'll debate that. Let me just focus on the academic. There, skin rash was an option. I think so, doctor. I mean, giving arthralgia and arthritis both would not matter. I mean, they may not have written dermatological eruption. They might have written the word skin rash, but the gist of the question is still the same. And yes, yes. Severe abdominal pain. Fine, doctor, I get your point. In case we do not have GI hemorrhage, then severe abdominal pain would be the answer to this question. But the way I have it at the moment, GI hemorrhage. Sneha, I got your point. If GI hemorrhage is not there, answer would be severe abdominal pain in severe abdominal pain would be the answer. We have references here. I mean, steroids would be used even in severe abdominal pain. Ezio got it. I mean, severe abdominal pain would be perfectly fine. And in case it is severe abdominal pain and GI bleed, I'll go by the worst case scenario. I mean, my logic for this question would be that whichever among these is gonna be the worst case scenario, that is where we are gonna go ahead and use steroids in this patient. Okay, fine, fine, doc. Amrit, that bleeding part is sorted in a sense that both things are given. He's mentioned first bleeding and then he's mentioned the severe abdominal pain component. Okay, Hemant, thank you so much for your kind inputs. And we move on to chronic bipedal edema. Yeah, I think it was again a not question. So just let me know whether this not thing is fine. CLD will cause albumin values to be lesser. So there would be a decrease of oncotic pressure and therefore edema would come in. Nephrotic will also cause the same thing. Option number D was renal failure. Again, there's going to be increased aldosterone in the body. And in all cases, renal failure, there's a hyperaldosteronism, so there would be presence of edema in this case. But when it comes to chronic venous insufficiency, that would be causing a unilateral manifestation. Yeah, least common cause. Okay, fine. The gist of the question is still there, least common cause or not a cause. So that would be chronic venous insufficiency. I'll just modify that, least common. Yeah, least common cause of chronic bipedal edema. That would be again chronic. The answer would still remain the same, doctor. Chronic venous insufficiency is usually a cause of unilateral. So that helps us solve this question. This, I think the pharmacologist has taken care of. We are having a diabetic patient. He's having heart failure, and maybe the wordings may not be accurate, but the question was which of the following drugs will prevent the further deterioration of cardiac function of these patients? Uh, okay. Hemant, that is a very interesting input that you gave. It was heart failure, but yeah, I would just like to wait for other people to comment. Yes, guys, sorry for just switching the slide again because one doctor mentioned that it was heart failure and then they asked what the least common cause. I think mix कर रहे हैं because heart failure तो नहीं देगा. I don't think so that he'll mention heart failure in this one. Okay, Hemant, I take your point. I'll look at that option as well. But anyway, that will change the entire dynamics there. अच्छा, heart failure was there instead of nephrotic. वो हो सकता है. That could be a possibility that instead of nephrotic, it could be heart failure in a question. हाँ ठीक है, fine. Heart failure and then it's gonna be instead of nephrotic, no, that could be congestive heart failure in the options. Got it, guys. Got it. I think that heart failure option would be in place of nephrotic syndrome. That doesn't change the answers. Fine, I'll still stick with chronic venous insufficiency. The next one talks about SGLT2 inhibitors. So this I don't need to debate. And yeah, Amit, thank you for the inputs. Empagliflozin will improve cardiovascular mortality. Traditionally for CHF, they ask about A plus B, but apart from A plus B, aldosterone antagonist, and then empagliflozin will do the job in this one. The next case talks about a 10-year-old kid treated with antibiotics for follicular tonsillitis, swelling around the eye, and there are eosinophils cast present. So he's talking about AIN in this particular case, allergic interstitial nephritis, mainly because of the antibiotics. Eosinophils we usually read with respect to three disorders. One is interstitial nephritis, then it's gonna be atheroembolic kidney disease. I mean, there are only three MCQs. If you listen to the kidney section, I've explained that जहाँ पे eosinophil cast लिखा होता है, तो eosinophil cast AIN में होता है, then atheroembolic kidney disease में present होगा, and thirdly would be present with respect to schistosomiasis. So the correct answer for this one is option number B. Remaining were not be very suitable. Okay. So the question is on for that discussion as well. Was it WBC cast or was it eosinophil casts? Yes. If it is WBC cast, I'll then start thinking in terms of possibility of, I mean, different perspectives. Eosinophilia in the blood was there. Okay. Even then, doctor, even if it's eosinophilia in the blood now and WBC cast, even then it is AIN. Okay, got it. Hemant, you gave a very good input, and still the answer is AIN. I would like you to focus on this fact that even in AIN, there would be presence of WBC casts as well, because one of the WBCs is eosinophils, na? So it's a possibility he could have not written eosinophil cast in this MCQ. I got the gist of the question now. Great, Hemant. That's a very good recall. It's mentioning eosinophilia in the blood with WBC cast. The answer is still AIN in this particular case. Got it, Animesh. Karak, thanks for the input. That doesn't change the answer in the question. The answer is going to be B. And the logic is that this would be allergic reaction to the drug intake that was present. So yes, Saurav, great. I mean, good that we had this discussion because it was eosinophil cast, but then WBC casts are going to be seen and specifically eosinophils. I mean, this data that I mentioned is specifically for eosinophil cast. This data that I mentioned is specifically for eosinophil cast. And as far as AIN is concerned, it would be mentioned as eosinophilia with WBC casts. That's okay. And along with flank pain. Okay. Hemant, let me know costovertebral tenderness in the question. I just want to rule out pyelonephritis one last time. He's already on antibiotics now, so to have a development of pyelonephritis in settings of antibiotic would be relatively lesser. Fever is okay. Flank pain is fine. So I get that point. But yes, I'll just write that word flank pain here. So unlikely ना यार, clinically तो हम नहीं बोल सकते ना, pyelonephritis का diagnosis is like a big thing to be said. You need culture for that. You need a uh, I mean, we need to prove that the culture report is positive before I say pyelonephritis. And since the patient is already on antibiotics, then considering the possibility of pyelonephritis would be unlikely. Okay, thank you, Dr. Ghosh, for that input. Antibiotics, WBC cause eosinophilia and flank pain. Fine, doc. I stick to my answer there, and that AIN again has presence of WBC cast. In fact, if you listen to the urine microscopic examination, I've said that WBC cast are a feature of pyelonephritis and then AIN. The pyelonephritis is not in the options. Okay, Saurabh, your comment just went a little up, so I just want to check it out again. Okay, Saurabh, I'll come back to your answer. It's just hidden in my phone at the moment. I'll just check it out. Let's look at the next one. Two options for RTA2 and two options for RTA4. I just want to know if it was incorrect statement and whether option number A is the way it is, RTA with hypokalemia. Waiting for your comments for this one. Incorrect option. पाइलोनेफ्राइटिस यार कल्चर पॉजिटिव पे पाइलोनेफ्राइटिस बोल सकते हैं ना. पर्सन ऑलरेडी एंटीबायोटिक ले रहा है, तो कोई ऑलरेडी एंटीबायोटिक खा रहा है उसको हम बोलें कि तुझे पाइलोनेफ्राइटिस हो गया, थोड़ा सा अनलाइकली है ना. और इसनोफिलिया वुड नॉट बी अ फीचर ऑफ पाइलोनेफ्राइटिस. ठीक है, फिर तो इनकरेक्ट स्टेटमेंट हमारा RTA4 के एसोसिएटेड विद हाइपरकलीमिया ओनली, सो दैट बिकम्स द आंसर टू दिस क्वेश्चन, द इनकरेक्ट स्टेटमेंट. फाइन. ठीक है guys, let's move on to the next one. Spastic quadriplegia, and he says what is the site of the lesion present in this case. तो quadriplegia तभी होता है जब या तो सर्वाइकल स्पाइन में इंजरी होती है, या अगर सर्वाइकल स्पाइन की जगह पे एरिया 4 ऑफ द ब्रेन इन्वॉल्व होता है. एरिया 4 ऑफ द ब्रेन वुड बी मोटर होमिनकुलस विच इफ डैमेज्ड कैन कंट्रीब्यूट टू डेवलपमेंट ऑफ स्पास्टिक क्वाड्रिप्लीजिया. तो इनमें अगर ऑप्शंस देखते हैं तो बेसल गैंग्लिया तो नहीं होगा और सेरिबेलम भी नहीं होगा. सेरिबेलम डैमेज में हाइपोटोनिया हो जाएगा, बेसल गैंग्लिया में रिजिडिटी हो जाएगी. तो पीवीएल एंड सिस्टिक एन्सेफेलोसील वुड बी प्रेजेंट. ओके, अच्छा पेशेंट नहीं था, टर्म बेबी. ओके, टर्म बेबी पे इमीडिएटली ओके बर्थ एस्फिक्सिया का कॉम्प्लिकेशन बता रहा होगा, या फिर ही कुड बी टेलिंग रिगार्डिंग ओके गॉट इट, term baby and then spastic quadriplegia. So he's either talking about birth asphyxia manifestation or he's talking about a manifestation of neural tube defect. Okay, encephalomalacia. Okay. Okay, fine, got it, guys. I mean, the correct answer for this one would be option number D. That would be encephalocele only. Cerebral. Did they mention the word cerebral palsy in the question as well? Did they mention a spastic child is brought, spastic CP child is having quadriplegia? Okay, term is not present. तो रूटीन केस होगा यार, जैसे बच्चा बड़ा हो गया अभी तो उसको. Doc, let me explain. Spastic diplegia is a presentation of periventricular leukomalacia. Can have a quadriplegia as well, but usually the usual manifestation of PVL will be a spastic diplegia only. But encephalomalacia, involvement of the brain would be more in favor of that. Okay, Tejasvi, maybe like your relay is coming a little delayed than where I am at the moment. Okay, Hemant, thank you so much. I'll have a look and I'll revert back to you. At the moment, guys, the answer for this would be option number D, that is a cystic encephalocele. And thank you, Dr. Aniruddha Ghosh, for that inputs as well. I think they are related to the manifestations that you were trying to talk about, right? Okay. Yeah, I think there was only patient with spastic quadriplegia. There was no otherwise. तो बहुत ज़्यादा वो हो जाता ना कि भाई birth asphyxia present है नहीं है, that changes the entire game. Then I'll think in terms of PVL also, because PVL is what you read after birth asphyxia. So if he's talking about a delayed cry in a baby, if he's describing me that this was either a term or a preterm baby, and then he's telling me, then I'll think in terms of PVL. But if he just says spastic quadriplegia in a person, either it's cervical spine or it's gonna be area 4 involvement. So that's where I'll think in terms of possibility of cystic encephalocele. Okay. So the answer for this one is option number D, and we can move on to the next one. This we are gonna really enjoy now. Not that I would say enjoy in the sense that it's a literate discussion that we'll have on this one, because I really want to know the exact ECG that came. This is the best one that I could lay my hands on for today's discussion. 55-year-old man, no troponin values given. Let me know. Yeah, doc. I will be doing that. I'll be doing that. So, I mean, sure. They would be, the discussions would be on very soon. Okay, Pratik, that's a good answer. That is non-estilation MI. My only concern is that a non-estilation MI and unstable angina, how would we differentiate between the two? Okay, term baby was described. Fine, doc. I'll add that there. Maybe he's mentioning a term baby only. Okay. Yeah, ST depression in lead number V2, lead number V3, and lead number V4 is there. That's very much there. So this first becomes a non-ST elevation MI. My only concern is that how do we differentiate between the two, because there is no mention of any troponin I value. So I think that he's trying to trick our mind. He's trying to see acute myocarditis, everybody could rule out because there are no pathognomonic findings of acute myocarditis. Option number D can be ruled out primarily because of the fact that acute myocarditis, it is always written in the book, non-specific ST segment changes. By non-specific, it means there are no pathognomonic findings, so that can be ruled out. Chest pain for 1 hour, okay. Yeah, since there is no troponin, that's what I'm trying to say, no, because to differentiate between unstable angina, if I say non-ST elevation MI, then answer can be unstable angina also, because unstable angina will also be having a ST depression present in the case. See, in this particular case, why answer is not A versus B. My first thought process when I had a discussion was that this should be a case of non-ST elevation MI, because unstable angina again would be having crescendo attacks and there would be like multiple attacks present in a person. But point is ECG findings for both of them are same. So if I'm saying B, then I cannot justify A. And if I say A, I cannot justify B. So I have to solve it by exclusion for posterior wall myocardial infarction. And well, the suggestion for that would be, I mean, why am I focusing on posterior wall MI at the moment is some diagnostic criteria which are present in this particular case. One of the diagnostic criteria would be that there is a ST depression, that's okay. It's more of a horizontal ST segment depression that is present. And more importantly, there is no T wave inversion. You can still see that in this case, I mean, why features in favor of posterior wall MI, I'll say them, and then I'll say features in favor of non-ST elevation MI. The T waves in this case are upright. Normally, whenever we have ST depression, present, then it is always associated with a T wave inversion. But in this particular case, there is T waves which are upright. That is one basically. Yeah, if changes are present in V7, V8, V9, then it is easy. If he's mentioning V7, V8, V9, was V7, V8, V9 mentioned? No, guys, I don't think so. There was no mention of V7, V8, V9. I am saying features in favor of posterior wall MI in this person patient would be V2, V3, and V4 having a ST depression, which is more of the horizontal type. Along with that, the R wave is more than the S wave in lead number V2, and T wave is upright. These three features go in favor of a posterior wall myocardial infarction. Guys, let me know if troponin values are given, because that will totally change the game in the question. I think troponin values. Yeah, there is no mention of any V7, V8, V9. That's okay. But there are still features which are going in favor of posterior wall MI. So we are still debating whether we should answer. See, my only logic is if I answer non-ST elevation MI to this question, then how will I rule out unstable angina? Because unstable angina will be having the same. And most of the time, if it is going to be a non-ST elevation MI, at least you should write the word, non-ST elevation MI anterior wall. There was no anterior wall also even described in the question. He just mentioned non-ST elevation MI. So if he's asking me in this question for the infarct localization, considering that this would be a question based on exclusion, no bradycardia was seen. No, bradycardia is not a feature for, there is no bradycardia as a diagnostic feature for any one of them, guys. Yeah, it is correct, Jatin. It is correct. If it is troponin I values are given, even then posterior wall myocardial infarction would be correct for this one based on the current values which are given. Okay, guys, even if troponin values are given in a question, it will still confirm the diagnosis of MI. That will just rule out unstable angina for me. Suppose in this MCQ, there was mention of, suppose in this MCQ, there was mention of troponin I, then unstable angina can be ruled out. So all we have to do is fight about non-ST elevation MI and posterior wall MI. Now, if it is a non-ST elevation MI, then as I've said, it should be producing a concomitant T wave inversion in the patient. But considering that if these features that I mentioned, upright T waves are present, R wave height is more than the S1, and then, yeah, I agree. Everybody wants their answer to be correct. I have gone through this stage, guys. I mean, whatever we have answered is correct. But on the basis of whatever ECG that I have in front of me at the moment and the concomitant data that is mentioned, I would answer this as a case of posterior wall myocardial infarction as compared to non-ST elevation MI. If I change this ECG and I mean, if I don't have these criteria present, then I'll answer this as non-ST elevation MI. So I think we are sorted for our discussion for today, and I still have like that dengue one I have not touched on because it has been deliberated multiple times. By fifth day, I think NS1 antigen would be the correct approach, and I have a table for the same as well. I mean, NS1 antigen is a good way for identification. After 1 week, I think it is IgM, MAC ELISA, and IgM antibody that would be significant. No, no, Dr. Anusha, that pain of 1 hour would not be a very significant one. And okay, there is, yeah, nausea, vomiting. That's okay, doc. Chest pain, nausea, vomiting can be occurring in any variety of MI. No, 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 Ankita, we cannot diagnose angina on the basis of duration. See, you cannot diagnose a cardiac event on a basis of duration. Na? You have to always evaluate the biomarkers in a question. And since a couple of people are saying that biomarker was given, that helps me just rule out only one unstable angina. That me confirms diagnosis is MI, and that is when we can think in terms of other possibilities as well. Mohan Raj, you're right, but then PCR regularly being okay, Beast, I know that PCR would sound like a very attractive option in this particular case. नहीं 5 days पे आफ्टर 5 days नहीं बोला ना 5 days पे पूछा ना वो तो आफ्टर 5 days it would be IgM antibody but otherwise we'll go by routinely we go by NS1 antigen and then we supplement it with that is what is routinely done, that is the routine protocol that is described. Can we diagnose MI without biomarkers? Doctor, we can diagnose if there is no, if these are the options that I'm having, no, there are two MIs and then there is a angina and there is a myocarditis. Then if I look at the options, I'll have to identify myocardial infarction. Yes, we can identify any one of the two can be positive. ECG can be positive or biomarker can be positive. So answer to your question is yes, doctor, that it would be we can diagnose MI on ECG alone and not on basis of alone biomarker. We don't need and, it is not and, it is or. So that I hope answers your query. Okay, okay. So I think doctor will still go by NS1 antigen, right? And then subsequently the antibody. Why not angina in this case? Okay, angina का मैंने reason दिया, मैं फिर से बोलता हूँ. Angina, unstable angina is an accelerating angina. So there are multiple episodes of chest pain that are experienced by an individual and they increase in severity and duration gradually. तभी उसको accelerating angina बोलते हैं ना. So here there's a single episode that is present. A patient comes to my hospital with single episode, यार MI तो सोचना है ना. Worst heart attack is like the commonest thing that we have to think. तो पहले तो common diagnosis सोचना है कि भाई MI है. और उसके बाद में based on the ECG parameters we'll have to identify non-ST MI versus a posterior wall MI and no, I agree non-ST elevation MI anterior wall is more common as compared to a posterior wall myocardial infarction, agreed on percentage value, but if I focus on the criteria and the features which are given then I'll say that this is posterior wall myocardial infarction. So guys, thank you so much for your inputs for today, and what we'll do is we'll put up a refined version of the same available in the app as well. And doctor, I try to do my best. Whatever options I get, I did spend time on them, deliberating with multiple students in various groups, and they were kind enough to, I mentioned a few names also. I mean, these doctors, in spite of studying, they were helping me with the options as well. Guys, you are at the standing at that particular part in your life where, you know, after few years you are gonna laugh on this कि यार हम stress ले रहे थे क्या जिंदगी में, मतलब क्योंकि the stress part is really the earning part ना. Once you get into that phase where you have to support your family, where you have to earn for your kids, when you have to ensure that your job security is there, because after all, you know, a corporate hospital is gladly gonna change you very soon. The moment you start asking for a salary raise, no, they'll say, "Jao, right? I'll hire a younger guy." So I think this is the time when you guys are at the threshold of, you know, that entering into that phase where you are able to handle life in a better way. So I would take it chin up. I would take it straight on. Yes, I am learning. I am analyzing my faults. I'm trying to focus on what are my weaknesses, because you see, being a human being, it's all about trying to improve on my weaknesses every single day. I mean, that has been my motto. That is what I try to do. uh, all I can say is, being an average student, I've tried to upgrade myself on a regular basis. And if you do it on a daily basis, then you are able to, pull through any obstacle that is present. So I think all of you are gonna be very hardworking boys and girls, and you are gonna do extremely great in your careers. And this is just a small obstacle that has really occurred, but it should not be upset in your mind, because like when you treat a patient, you don't get emotionally attached to a patient. No, if you lose somebody, you don't cry, and if you save somebody, you don't start partying. Similarly here, I want you to exhibit a emotional apathy to all MCQs. If they go correct, cool. If they go wrong, okay, fine, I'm gonna try and see what went wrong. इधर आता नहीं था या आता हुआ गलत हो गया, जो आता हुआ गलत हो गया उसको इम्प्रोवाइज कर लो यार। नहीं आने का तो लिमिट इज गोना बी वेरी extensive one. Hemant, sure, I will let you know much more details once you send me an email across. I think you have sent me, and I'll start reverting back to you. So we'll focus on many others. And I will be doing it, guys. Sure, I'll be taking care of the subsequent revision sessions for you guys as well. So you will just keep on doing it on a daily basis. No, we just have to improve on daily basis. Just try to do those small things daily, which make us a better person. I mean, it could be like doing 1 hour extra study. It could be doing half an hour of less sleep. It could be like maybe doing is when you're tired with 50 MCQs, try doing 55. I mean, that's the only thing one can do. So yes, guys, you are gonna do great. Okay, guys, God bless you. Take care. Bye bye.